Hi everyone and welcome to my Mahara page. My name is Aaron King and today I'm going to be running through my simulation of a cardiac chest pain. So this flowchart behind me is basically being designed by myself and a little bit of first year's content as well. It focuses a lot on the methodical part of going through a chest pain scenario. So initially in my first and even into my second year, I've been a bit of a culprit of getting caught stuck in scenarios, just not being able to press past some of the obstacles that are thrown to me at the scenario. So this diagram helps me to sort of just work through the scenarios and making it flow, I guess. So the communication skills I usually seem to have down pat, and the communication with my patient, I'm able to get most of the ampoule and the dollar from it. Okay, so I'll start running through the flow diagram we've got here. So obviously we've been dispatched to a chest pain patient. With any case, we've got to make sure we've got our protective personal equipment. That's not just for us, but for the patient, as well as not failing the OSCE. Then we go through our Dr. ABCH. So, we remove any dangers if there is any, or don't enter the scene, and we run through it. But for the case of our chest pain patient, we're going to assume that yes, he is actually breathing and he's got a circulation and there's no major hemorrhaging. Okay, so then this is the part for me that I sort of go alright in, and this is building up a rapport with the patient. So this is when we first enter, just that initial encounter is most important so that you get the patient on side. And that might just be saying, hi, my name's Aaron, a simple introduction, this is my partner Joe, we're here to help today, how may I help? Tell us a bit about what's going on. And just from that little interaction, you're going to have the patient's immediate attention that, yes, you're here to help, I'm going to answer back to you. And there's going to be nearly a trust build-up just from your rapport building. So this is really important. So this is also contributed to your initial first thoughts about the patient. So already this patient's said, oh hi, I've got a little bit of chest pain, and if this patient's sweaty, I mean he's complaining of chest pain and he's just not looking great, white as a ghost, you might be already starting to think to yourself, okay, this patient might need the monitor on right there and then, and you can just go ahead and get your partner to put on the dots. Say to the patient, hey mate, is it okay if I just put the dots on? We need to have a quick look at what's going on with your heart. I'm a little bit concerned about that. And then if we need to, we might just call for Micah there and then straight up. Okay, so this is, say that isn't the case and we don't call for Micah, we're going to keep pressing through this flow chart and we're going to go straight into dollar and our ampoule. Okay, so obviously the dollar and the ampoule is the most important part about a chest pain. So we're going to be able to work out, which I'll show you later, whether it is cardiac, pleuritic or traumatic, and this is really important for our treatment of the patient. But initially we're going to be we're just going to ask general dollar questions, and I'll go through this a little bit later. And we'll move to ampoule, and this is where we look at getting a history from the patient. Have they had some sort of AMI in the past, or is there a history of AMI in the family? This is if they can't remember, if they don't know, if they haven't got a conscious state that's able for you to tell them. You can always look into their drug basket. Most of people who have got a history have got a large basket, and from that the paramedics should be able to work out, okay, so this person's on this drug, which means it's possibly because of this. So once we've established a bit of a history and our dollar, we move on to our vital signs survey, and this has got to be, a little bit incorporated into the dollar and the ampoule. It's not to say that we're going to stray away from the dollar and ampoule too much, but we do want to get the vital signs survey in there just in case the patient does deteriorate while we're on scene. Okay, so we establish our PSA, our RSA and our GCS, and we move down to a secondary survey, which is a head to toe, and we do the systems approach. Okay, so from all of this we established, okay, you've got a couple of things going on, and the main presenting problem for you today is that you have got chest pain and you're feeling a little bit nauseous. Okay, so then we're going to go ahead and we're going to treat for the chest pain, and we're also going to treat for the nausea, and that's going to come under our treatment of cardiac chest pain which I'll describe later on. Okay, so getting back to our dollar and amp, which is straight back up here, this is the most important part for me when I go into a scene, because this is what's going to tell me whether I'm going to take the course of action for a cardiac, a pleuritic, or a traumatic chest pain. And each of these will differ with the treatment that we're going to give to our patients. So it's essential that we take the time out to actually work through a dollar and an ample. A sick patient, although they're sick, they may go into cardiac arrest while you're on scene. But if we know this before they do, it's going to help us a lot in the long run for the patient. Okay, and well, with our treatment at least. So the few ways that we can work out whether this patient is actually a cardiac, traumatic, or pleuritic chest pain type patient is working through this dollar, and there's a few significant little features within each one that we can either ask the patient or the patient's going to tell us. So with the cardiac, we're going to be looking at describing the pain, and it's going to be more towards the dull, the heavy, someone's standing on my chest. That's the feelings that they're going to be describing to you. Be careful if they say it's coming along with exercise. We might be thinking, okay, this patient might be having angina right now, which is going to be a bit different to something like pleuritic or traumatic. This patient is going to be able to not localise the pain so much. So they might just say, oh, it's really dull around the chest area. Oh yeah, and I've got a bit of pain down the arm. Okay, so if you hear that, that's common symptoms of cardiac chest pain. I've got pain in the chest, it's not localised, it's spreading to my left arm, it's going up into my jaw or into my back. That's typical symptoms of cardiac chest pain. And we would be thinking from there, this patient is having an episode of angina, unstable angina, STEMI or non-STEMI. So to work out that, it gets a little bit more tricky, but essentially if the patient is taking this GTN, then we're going to assume, and the pain has actually gone away while you're on scene, we're going to assume that this patient has actually had an episode of angina, and if it's unrelieved, we're going to say that this patient's got unstable angina. And the way we can tell between the STEMI and the angina is obviously if we get a 12 lead with mica. Alright, so moving on to pleuritic. This patient can present similar to traumatic, but there are a couple of major differences. So obviously we've got more sharp paining that's going to be described as like a stabbing kind of feeling in the chest. Obviously the onset is going to be either gradual or sudden, depending on how long ago the infection in the chest has gone on for. It's very well localized, and the main difference for the pleuritic chest pain is going to be when they inhale. So if that pain changes on inspiration, then that's going to ring alarm bells and think to yourself, well, this patient might actually be a pleuritic chest pain and not actually a cardiac chest pain. The patient is going to be short of breath, and they generally have a chest infection prior to you getting there. Whether they know that or not is something different altogether, but they probably have a chest infection. This pleuritic chest pain really falls back under your secondary survey. You want to hear what you want to have a good look and a good listen to their chest to see what's going on, and you pick that up with things like your temperature. If you've got a pretty warm temperature, you might be seeing some sort of infection happening there. The patient won't be relieved of pain with nitrates, and their position might actually help them a little bit when they curl up forward. So with a traumatic patient, this patient has most likely been in a fall or a car accident, or something has actually hit their chest that's causing the pain. This is again really, really noticeable in your secondary survey. Have a good look at the patient's chest. Is the patient's chest bruised a little bit? Is there something that's not quite normal? Is there lumps appearing on the chest that you're not confident is related to cardiac or pleuritic? Now the onset is gradual or sudden. That depends on how long ago the accident occurred. Either it's going to be sudden if it just happened then, or it might be gradual. It's built over a few days after the bruising has occurred in the chest. So this pain can be well defined. if you've been stabbed in the chest, or if you've fallen on a corner of a desk, then you're going to feel that straight away, and it's going to be pretty sore in one certain area. The patient might be a bit short of breath, and obviously there'll be no relief with nitrates, and the position may help again. So hopefully this is something that I always keep in mind, that when I first walk into a patient, I want to work out which of these I'm going to take the course of action. And as far as what we're going to take in this scenario, we're going to take the management of a cardiac chest pain, because that's essentially what we've been learning all semester. So here we go through the typical management of cardiac chest pain. We're going to call for mica potentially straight away. So if you think this patient, yes, indeed, he is looking quite sick, he's ticking all the boxes for a typical STEMI or angina episode, we're going to get straight on the phone to mica, and we're going to ring and get him to come down with the 12-lead ECG, and he's going to give a little bit more treatment than what we can as well. But initially, the typical ALS paramedic is going to give them aspirin to chew on, 300 milligrams orally. We're going to establish an IV access. That can be sort of teamed up with your partner, so your partner may want to get that all ready for you, and then you're going to put the line in yourself. That's up to you and your partner, I guess. GTN, we want to drop this guy's blood pressure. We're going to vasoconstrict all his vessels, and hopefully we're going to reduce all the workload on the heart. We'll give him every 5 minutes he's going to receive between 0.3 and 0.6 milligram. And then we also want to reduce his pain, so give this patient some morphine at every 5 minutes. Obviously remembering that the maximum dose we can give as an ALS paramedic is 20 milligrams. And if allergic, keep in mind, you want to find that in your ampoule. If he's allergic, you want to just give him fentanyl instead. So this is my basic approach to a clinical scenario. Like I said, it's something that I'm always building on, and it's going to keep getting built on with the more knowledge that I build up over the years. But essentially, this is what I've established as my cardiac chest pain. So yeah, thanks for listening.